Assalamualaikum.
Waalaikumsalam.
Oke ya. Orang ada yang belum masuk tapi oke lah. We start already 8 o'clock. Let's start with kitab Al-Fatihah. Bismillahirrahmanirrahim. Okay, today we will discuss 3 topics about the nephro topics lah. The first 2 will be connecting each other, yeah, about the acute kidney injury and chronic kidney disease. And then the next one, the last one, will be about common complaint in clinics, yeah, and Enuresis. So let's learn together today, and then nanti especially you need to know how to differentiate, how to diagnose acute kidney injury and chronic kidney disease, as well as nanti Enuresis. Ya. So belajar, nanti biasalah nanti usual rule, nanti kalau tak nampak gambar tu akan saya panggil, yang tak nampak video. Yang nampak video kan dah tahu muka-muka yang belum mandi ni dah nampak dah. Yang tak nampaknya saya panggil masih tidur kok. Alright, so Adlan can start.
Okay. Bismillahirrahmanirrahim. Can you hear me?
Alright.
Yes.
Okay. Bismillahirrahmanirrahim. Assalamualaikum and a very good morning. I bid to Dr. Taufiq and fellow friends. Salam Maulidur Rasul. So today our group will present on a seminar regarding kidney problems, which are acute kidney injury, chronic kidney disease, and also Enuresis. So start with me. I am Adlin Afika Ahmad Dahlan, metric number 1615678. I'm going to present on acute kidney injury, AKI. So this is my outline. Okay, so we go to the definition first. What is AKI? AKI is an abrupt rise in serum creatinine level, decrease in GFR, resulting in inability of kidneys to regulate fluid and electrolyte balance. This is based on pediatric protocol, 4th edition. So before this, we usually heard about ARF, acute renal failure. However, this term is kind of overemphasized, and it actually affect the management, the whole management of the patient, as well as the mortality rate. So that's why they come up with this term acute kidney injury, in which it comprises from even the small changes in serum creatinine level to the to the complete renal failure. So this is the staging for AKI based on KDIGO CPG for AKI 2012. So before we stage AKI, we have to know the baseline creatinine, serum creatinine. I'm sorry, I forgot to mention here. So the baseline for children, the baseline creatinine level for children below 3 years old is 0.3 to 0.7 microgram per deciliter, while for children 3 years old to 18 years old, the level is range from 0.5 to 1.0 milligram per deciliter. This normal range I got from website University of Rochester Medical Center. I couldn't find it in PITS protocol. So according to the staging AKI, the stage 1 for serum creatinine, it is between 1.5 to 1.9 times of baseline. For stage 2 is 2 to 2.9 times baseline, and for stage 3, it is 3 times baseline, or increase in serum creatinine to at least 4 milligram per deciliter, or initiation of renal replacement therapy, or in patients below 18 years old, decrease in eGFR to less than 35 ml per minute per 1.73 meters square. Okay, so next we move on to the common causes of AKI. Based on PITS protocol, it has been divided into pre-renal, intrinsic, and post-renal. So for pre-renal, it is mainly characterized by the renal hypoperfusion, in which the structural kidney is still intact. So for pre-renal causes, it includes hypovolemia such as dehydration, bleeding, third space loss such as nephrotic syndrome and burns, distributive shock, and also cardiac failure. So if this pre-renal cause treated early, the renal function will returns to normal. If it does not treated early, it might cause intrinsic renal parenchyma damage. So come up to the next causes, intrinsic causes, in which it characterized by the renal parenchyma, which has been damaged due to sustained hypoperfusion and ischemia. So the diagnosis for these causes are acute glomerulonephritis, such as post-streptococcal glomerulonephritis, lupus nephritis, HSP nephritis, and also membranoproliferative glomerulonephritis. Other than that is acute tubular necrosis, or we call it ATN, which normally caused by hypoxic ischemic injury and nephrotoxic insult. Other intrinsic causes are endogenous toxins such as myoglobin and hemoglobin, exogenous toxin from antibiotics such as aminoglycosides, chemotherapy, and also snake venom. Infection may also cause AKI, which is pyelonephritis. And for vascular causes is ACE inhibitors, vasculitis, hemolytic uremic syndrome, renal vein thrombosis. Not to forget tumor lysis, in which we know that tumor lysis is a massive tumor cell lysis, which release a high amount of potassium, phosphate, and uric acid. So when this uric acid increase in renal tubules, it will cause obstruction. That's why it can lead to AKI. Okay, so for post-renal causes, it is usually related to the obstruction of urinary tract, such as posterior urethral valves, acute bilateral ureteric obstruction, and also acute obstruction in solitary kidney. So pop quiz, can unilateral obstruction cause AKI in children with 2 functioning kidneys? Anybody knows?
No.
Tembak je.
No.
No, because
Compensated
Oh, no.
by the other functioning renal.
pardon? Ifa? Is that Ifa? Ifa?
Compensated by the other functioning renal, the function of renal.
Okay. Bolehlah kot reason. Yeah, the answer is no. The AKI in children with 2 functioning kidneys is usually should have bilateral obstruction to cause AKI. So unilateral tak boleh. Thank you, Ifa. Okay, next is clinical features of AKI. So children commonly will come with oliguria, in which for neonates is the level is less than 1 ml per kg per hour, and for children is less than 300 ml per meter square per day. Other than that, children with underlying causes like acute PSGN, they might come with recent pharyngitis together with periorbital edema, hypertension, and gross hematuria. For the children with underlying congenital tract obstruction, they can come with palpable bladder. So for the AKI can be also caused by dehydration, right? So children with persistent vomiting and diarrhea, we should take note on the AKI symptoms. So next is systemic diseases. Children with lupus nephritis or HSP nephritis can come with rashes or arthritis. And last but not least is the children with AKI. They might already come with symptoms of complications such as seizure and shortness of breath in acute pulmonary edema. Come to investigations of AKI. So the first one is full blood count. We should look for anemia, leukopenia, and also thrombocytopenia. The next one is blood urea and serum electrolytes and creatinine, in which in AKI, the results usually shows elevated blood urea and creatinine, hyperphosphatemia, hyperkalemia, hyponatremia, and hypocalcemia. For the arterial blood gases, we might find the result might be metabolic acidosis. Next is serum C3 complement, in which it will be depressed, especially in a patient with PSGN or SLE. So for antibody testing, such as anti-nuclear antibody test, this is usually done in patient suspected for SLE. And the last blood investigation, last lab investigation is UFEME or urinalysis, in which we might find out the results: hematuria, proteinuria, RBCs, and WBCs. So there are differences between intrinsic AKI and other kidney disease, in which in intrinsic AKI, there might be hematuria, proteinuria, and RBC CAS. But for tubulointerstitial disease, there might be low grade of hematuria and proteinuria, but increase in WBC. Okay, for other investigations, chest X-ray might be done if we suspect the patient have cardiomegaly or pulmonary congestion. So for renal ultrasound, it is an urgent if the case is unknown. So we might find the patient have hydronephrosis or urinary tract obstruction. So for renal biopsy, if the case is no clear defined of it is either pre or post renal AKI. Next is management. So before we go on to management, we have to know the common complications of AKI. So the first one is metabolic. Just like I have mentioned just now, metabolic acidosis, hyperkalemia, hyperphosphatemia, hypermagnesemia, hyperuricemia, hyponatremia, and hypocalcemia. For neurologic, seizures, escherichia, and mental status changes. And cardiopulmonary, such as pulmonary edema, arrhythmias, pericarditis, pericardial effusion, hypertension, myocardial infarction, and pulmonary embolism. For GI problem, AKI may cause nausea and vomiting, malnutrition, and hemorrhage. And for hematological, it might lead to anemia or bleeding. So this is the principal management for AKI. First is medical management, which include treating the underlying causes and manage the complications. And the second one is renal replacement therapy or dialysis. So for medical management, if it is in emergency setting, we have to do fluid resuscitation, in which we give crystalloids or transfuse blood, or if the patient is in hypervolemic, we give fluid restriction, and not to forget to monitor the urine output. So the second management is electrolyte imbalance. Okay, so for the hyperkalemia, it will show ECG abnormalities. Can someone mention about the ECG characteristics for hyperkalemia, ECG findings for hyperkalemia that you guys remember?
Alternated T wave.
Okay,
Prolonged
great.
PR.
Okay. Last one. Have alternated P wave, T wave, prolonged PR, and also widen QRS complex. Okay, so the next one is hyponatremia. If the patient is asymptomatic, we restrict the fluid. And for hyperphosphatemia, we give calcium carbonate orally with meals. If the patient comes with metabolic acidosis, we might replace half of the deficit with IV 8.4% sodium bicarb. And not to forget to monitor the arterial blood gases of the patient. Next one, the nutrition. Avoid excessive fluid intake. For the patient with intact GI, we can proceed with enteral feeding. If not, if enteral feeding fail, we give total parenteral nutrition, consists of concentrated dextrose, 25%, lipids 10 to 20%, and protein 1 to 2 gram per kg per day. For the medications of the patient, we might adjust their medications, avoid any nephrotoxic drugs, and concentrate the drugs to the lowest volume of dilution if the patient is in oliguric state. So you can see the treatment of hyperkalemia in AKI patients, in which we give IV calcium gluconate, IV dextrose, plus minus IV insulin. The fourth is IV sodium bicarb, and we nebulize the patient on site of action 30 minutes, and we give calcium polystyrene sulfonate or sodium polystyrene sulfonate. So the last option for in managing AKI is dialysis. So there are few choices, which are intermittent hemodialysis, peritoneal hemodialysis, and also CRRT, continuous renal replacement therapy. So in AKI, we usually treated with CRRT. So these are the indications for dialysis, which includes fluid overload, if the patient have a electrolyte imbalance, symptomatic uremia, oliguria preventing adequate nutrition, or oliguria post cardiac surgery. So the prognosis for AKI patient, for the mortality rate in children with AKI caused by PSGN is low. However, in children with AKI associated with multi-organ failure is quite high, which is more than 50%. For recovery prognosis, it shows good prognosis in AKI caused by pre-renal ATN, acute tubular necrosis, or acute interstitial nephritis, or tumor-lysis syndrome. However, it might be bad prognosis for patient in AKI caused by rapidly progressive glomerulonephritis, bilateral renal vein thrombosis, or bilateral cortical necrosis. Okay, so these are my references, SPITS protocol, CPG for AKI 2012 and Nelson 21st edition. Any questions?
Alright. No question? Oh, very clear Tapi nak panggil dulu ni. Siti Nur Adawiyah mana ada? Tak ada. Nama je ada, orang tak ada. Ni Safsu ni siapa Safsu ni? Tak ada juga. Itulah yang dah susah kalau online tu. Sometimes you just only join but don't even knows what is going on lah. Muslihana ada Muslihana?
Saya, Doktor.
Okay. Muslihana okay, clear.
Clear.
Tak tanya apa-apa? So,
Alhamdulillah, so far clear.
right. Okay, and then ini lagi Hazira, ada Hazira?
Ada.
Okay, tak tanya apa-apa?
Tak ada.
Apa definition AKI apa Hazira?
Definition ACI. Definition apa, Doktor?
AKI acute kidney injury.
Sorry.
Acute kidney injury, we discuss AKI now. AKI. Noisy Hazira ni, dia tak dengar.
Sorry,
And
tak
then?
clear.
Dan tadi dengar tak tadi Adrian present tadi? Can you hear presentation tadi tak? Itulah ini quite noisy ni Hazira ni.
Dengar, bukan definition yang tu. Ya, saya?
Okay lah, seorang lagi je ni. Siapa ni? Hani lah, Hani Afisha ada?
Ada, Doktor.
Okay, apa definition of acute kidney injury?
There is abrupt rise in serum creatinine level
Okay.
with decreased GFR. So it results in the kidney inability to regulate and also there is fluid and electrolyte imbalance.
Okay, nah. So yeah, it's simple je. Abrupt function of kidney tu dia tak unable to excrete the urine, so memang will be anuria with some other features lah, with hyperkalemia usually, metabolic acidosis, and then even acute acute ni the keyword is actually reversible nanti we discuss further nanti after the second topic, after chronic kidney disease, nanti kita compare between AKI, acute kidney injury, and chronic kidney disease. We can compare later. Keyword for acute ni usually reversible, especially kalau yang prerenal tadi, prerenal factors usually good respond to fluid management, usually fluid resuscitation, acute prognosis. But ada some issue juga kalau with MODS, with multi-organ dysfunction tadi ada poor prognosis juga. Even though kata reversible, tapi kalau with multiple problems, usually difficult to treat. Alright.
Doktor,
Yes.
kalau the patient is presented with hyperkalemia but it's just mild, less than 7, so do we treat with calcitic cocktail?
with cocktail. So Adeline jawab dulu, presenter.
Pardon, but level less than?
Less than 7. In the protocol, it said to give the lactic cocktail to more than 7.
Not sure, doctor.
Not sure. Tadi kan you already give the good message. Actually yang dulu kita diagnose acute renal failure ARF, fail dulu baru treat kan. So that's why the outcome were bad lah, banyak yang fail to treat, banyak tak selamat ya, not survive. So with new definition, acute kidney injury, even though very mild, if there is some changes, some derangement in the features of the function of the kidney, we can aggressively treat. So let's say dia dah start oliguria, potassium 6.5, kan masih below 7. For me, I will treat lah. Memanglah no complete as truly kidney injury kalau potassium more than 7, dah anuria, we need to very aggressive to do to do what we call it all out lah, including dialysis. Tapi kalau still mild, sama tadi kan still early or initial still early features, still initial, masih awal lagi, we can treat. Yang tak payah itu yang dialysis. Potassium more than 7, ada acidosis, ada anuria, barulah perform dialysis memang. Tapi kalau potassium less than 7, oliguria, we can do other treatment tuh, yang lactic cocktail tuh kita boleh start. Okay, and then cocktail treatment coba tadi show up your slide tadi pasal the treatment tadi, this one. Okay. So the treatment choice are there kan? Balik yang this there are berapa nih? 1, 2, 3, 4, 5, 6 choices about the treatment. Which one should you choose first, or will you do treat all this step together? Actually not really. Depend on the situation juga, depend on the severity juga. Usually the safest one actually number 5. Bronchodilator salbutamol pentol nebulization tuh, dia the safest one. Usually my preference kalau ada patient with early AKI, buat neb selain dulu, neb ventolin dulu. So tengoklah respon. Still not improving, so we go further with other treatment, because other treatment tuh need more close monitoring ya. Macam when we give insulin with dextrose tuh, we need to close monitor, because there is risk of hypoglycemia dia kalau terlampau banyak insulin, which is dangerous juga. Kalau kurang insulin too much dextrose jadi hyperglycemia, also dangerous. By cup pun it is not easy juga to monitor the ABG. Gluconas calcium maybe also safe, tapi complication is also there ya. Kalau you bagi gluconas calcium tuh IV, there risk of phlebitis ya, sampai ada burn injury juga. Banyak case burn injury due to bolus gluconas calcium. So kena tengok lah, be careful with this treatment. Bicap pun sama ya, when inject bolus bicap ya ada risk of phlebitis, burn injury juga. Terus this agent tuh dia memang korosif, apa nama dia? Bukan korosif lah, apa? Iritatif ya, irritating agent. So kena tengok ya, apa? Do we treat with all this apa namanya modality? Not really ya, depend on the severity. Sometimes with only nap pun dah improve, so okay lah. Patient apa potassium 6.5 for example tadi, with after nap dia turun jadi 5, okay lah. So we just proceed with fluid management supaya dia apa with adequate fluid, with diuretic supaya dia keluar kencing balik. Sometimes only that simple, yeah. But sometimes will be very difficult to treat, depend on the severity. Okay.
Doktor,
Yes.
tanya. So kalau adult, lactic cocktail consists of calcium gluconate, dextrose and insulin. So kita kena bagi number 1, 2, 3 at the same time all, ataupun memang macam doktor cakap tu 1, 2, 3 ikut turutan.
Itulah. So depend on the severity and preference. Pada saya itulah the safest one actually number 5. And then okay lah kalau if you want to give also gluconase is also okay. But as long as when you give to you know the possible side effect, possible complication that might develop, it's okay. You can give apa? Usually kalau memang truly kidney injury yang betul dah memang potassium more than 7 tuh, memang need all lah, need all gluconase, calcium, dextrose and insulin, and then apa nama bicap juga to treat because automatic lah. Usually patient-patient with anuria will develop hyperkalemia, metabolic acidosis. We need to treat all these problems kan. So how to treat acidosis? We give bicap. How to treat the hyperkalemia? We reduce the potassium to transfer to intracell with dextrose and insulin, and then gluconase calcium to stabilize the apa namanya the heart, myocard. All these statement kan have different purpose kan, and different route of administration and different apa pathophysiology, different route of mechanism ya. So we can see lah, for example patient apa ada develop tachycardia, better we give gluconase calcium first to stabilize the membrane tuh. And then next baru reduce the potassium with dextrose and insulin, and then apa bicap to increase the apa to reduce the metabolic acidosis. So as long as you know what's the purpose, you can go even 1, 2, 3, 4, or you can go together. It depends. It will be case to case basis. It will be you cannot do to same thing to all patients. No, depend. Maybe this patient you just only need nebulization. Other patient you need to give all. Another patient maybe you need only gluconase calcium with naps, depend. It will be case to case basis. Okay. Okay, nah tadi yang next slide tadi yang Adlin apa? Sorry, next slide ya. Bukan tadi, yang previous kok. Yang about the this one. This one is the comprehensive management kan. So we cannot only think about the medication kan. We need to think about the fluid, how to treat the electrolyte, how to treat the acidosis, what to do with the diet, and so on and so forth. So semua ini comprehensive holistic management. It's more important than think about what medication to be given. Macam tadi kan, you nak bagi satu je ke, nak bagi 5 ke, nak bagi 1, 2, 3, 5 in sequence ke, it is not really matters actually. The more important is this. How do you treat the patients comprehensively? Because again, it is common sense. And we don't treat the number, we don't treat the potassium level only, we treat the patient kan. Tengoklah patient tu kalau ada acidosis, we need to give backup. Kalau tak ada, maybe we can withhold, tak payah bagi backup. Kalau patient with hypoglycemia, for example, dia develop AKI, ada hypoglycemia, ya be careful lah. We need to treat the hypoglycemia first. Increase the glucose level dulu, baru give insulin. Or if vice versa, patient diabetes mellitus with AKI. So we don't give dextrose kan, we give insulin only kan to reduce the glucose level as well as to transport the potassium. Because in real setting, in the real world, in the hospital, no all similar situation. Different patient, different situation. Okay. So that's why we need to know how to manage comprehensively macam ni. And then strategi tengok. So just like you are an army, for example, wait a minute. Alright, comprehensive management, and then don't treat the number. We need to see the patient, which one is useful for your patient. Not always give same medication to all patients, because the choices are there. We need to choose it wisely. And another important message from from the clinical setting, from the patient, actually close monitoring or bedside monitoring. So we cannot treat the patient from home, for example. For example, if you are or even from the counter, you need to come to the patient, see what happened to your patient, and then sometimes you have really bedside to know what is the patient needs, because different patient has different problems, not all same. Even though sama-sama AKI, dia problem dia lain-lain. Kalau you jadi dokter duduk kat counter, what more kalau duduk kat bilik on call, tak tengok patient, atau only receive phone call from ED, you tak nak tengok patient, it will be problem. Itulah the spirit untuk jadi doctor is to do bedside, to know your patient, not only know the numbers. For example, you accept phone call, potassium 7, okay, bagi ini. You tak tahu the patient kan. It can be dangerous. The one who beside the patient is the best one to decide. Sometimes kan the problem, the one who beside the patient is the most or the youngest or the most junior doctors, kan, houseman or MOs, which is usually don't know what to do. So that's why kan need to consult. Ya, consult pun non discuss, bukan spesialis orang konsultan yang on the phone tuh yang really decide langsung. We give choices, see the patient, and then usually kan if in acute setting in ICU or ED macam ni memang usually spesialis should be bedside as well, because should be in house, should be active. Sometimes consultant tu dia passive je kat rumah. Okay, so itu ya message nanti kalau you jadi doktor, don't treat the number satu, and then bedside, beside the patient, see your patient. Ya. Kalau tak tahu patient bahaya. Sometimes you give wrong medication. Contoh tadi ya, patient diabetes, hyperkalemia AKI, suruh bagi dextrose pas insulin, ya, tak boleh. Insulin je, tak payah dextrose. Ya. Alright. Okay, any more question for the first topic? Dah already 40 minutes, ya. The second topics, okay, about the chronic kidney disease. Nanti after the second topic ni we discuss more ya about both ya, acute and chronic. Okay, Aisyah, you may start.
Okay, Assalamualaikum everyone. Before that, Dr. Sorry, I can open my video because I have very unstable network connection right now. Okay, so today I'm going to continue our presentation with second topic, which is chronic kidney disease. Yes. Okay, this is my outline for today. We will discuss about the definition, etiology, staging, pathophysiology, clinical features, the investigation and management, also the prognosis. Next. Okay, for the definition of the chronic kidney disease, it is an irreversible kidney damage with deterioration in kidney function that gradually progresses to end-stage renal disease. And according to Nelson 21st edition, it defined as a presence of kidney damage and level of kidney function irrespective of the diagnosis. And we always confused about the CKD and the difference with the end-stage renal disease. It states that end-stage renal disease is used to define all patients who are treated with dialysis or kidney transplantation, and is subset of patients with stage 5 CKD. Okay, next. And another definition is according to the National Kidney Foundation KDIGO guidelines, it defines the criteria that that patients must have fulfilled to say that the patient has CKD if either of the two following criteria. So the first criteria is when the kidney damage occur for at least 3 months and more, and is defined by first, presence of structural or functional abnormalities of the kidney, even with or without decrease of the GFR, and it manifests by one or more of the following features, which is abnormalities in the composition of the blood or urine, abnormalities in the imaging test, and abnormalities on the kidney biopsy. So this is the first criteria. Either the second criteria is when the glomerular filtration rate is less than 60 millimeter per minute per 1.73 meter squared per body surface area for at least 3 months and more, with or without the other signs of kidney damage described above. Next. So, according to KDIGO guideline also, they have staged the chronic kidney disease into 5 stages according to the glomerular filtration rate reading. So, stage 1 is more than 90, stage 2 is about 60 to 98, and then stage 3 into 2, 3A and 3B. And 4 between 15 to 29, and stage 5 is less than 15, or they also already described as end-stage renal failure where the renal replacement therapy is required. So this stage, according to the KDIGO guidelines, it is not applicable to patients who less than 2 years old because their GFR is normally lower than the value of our normal adult GFR. So if you use this staging, it can be incorrectly placed to stage them characterized by their greater renal impairment than their actual renal function. Next, so just a quick recap of how to calculate the glomerular filtration rate, and it is equal to the sum of filtration rates in all of our functioning nephrons. So according to the short formula, the serum creatinine is the most commonly used to test to estimate the GFR by obtaining the serum creatinine by blood sample. So the method is where the K value already fixed according to the patient's age, and we times by the body length of the patient, and we divide by the serum creatinine. So there is also another way that I found that the researchers investigate to use the cystatin C, which is a protease inhibitor, but the data not support because but the data not yet enough to use this formula, to use this method in pediatric population. So they still need more research. So next. So in children in CKD, there may be results from either congenital, acquired, inherited, or metabolic renal disease. And we can divide into the age of the presentation, which is less than 5 years old or more than 5 years old. So in CKD in children less than 5 years old, usually is mostly common due to congenital abnormality, such as first, the most common one is the renal hypoplasia or renal dysplasia. So renal hypoplasia is an abnormal small kidney with normal morphology, but they have reduced in nephron number. Renal dysplasia is an abnormal internal structure of kidney. So the second most common is obstructive uropathy, where there is an obstruction at ureter that results in backflow of the urine into the kidney bed. And another common one is the congenital anomalies of kidney and urinary tract, or Acute. So this one are the most common cause of CKD for each of baby when they are birthed. So and the other causes such as congenital nephrotic syndrome, Prader-Willi syndrome, cortical necrosis, focal segmental glomerulonephritis, renal vein thrombosis, and also hemolytic uremic syndrome. So that's a common in the children that less than 5 years old. For the children more than 5 years old, usually the causes are due to the acquired disease, which is varies from glomerulonephritis like focal segmental or lupus nephritis. Inherited disorders also can cause CKD, such as familial juvenile nephronophthisis, Alport syndrome, PCKD, and metabolic disorders such as cystinosis and also hyperrosaluria. So cystinosis actually is a disorder where there's a defective transport of amino acid out from the lysosome. So when we cannot transport the amino acid out from the lysosome, it got trapped inside it and become crystallized. So furthermore, it will further damage the tissue and organ. And hyperrosaluria is when our kidney it excrete the oxalates too much, and the patients will end up with having calcium oxalate kidney stones, which in the insoluble compound. So it can result in CKD in the end. So that's for the etiology. Next, we move on to the pathogenesis of the coronary disease. So just for a brief explanation. So it occurs when one half of our total nephrons are lost. So when the number of the nephron reduce, the remaining nephrons will try to adapt the functions of the functions of the kidney. They want to take back the function of kidney by increase the hyperfiltration at the glomerulus. So they call it adaptive hyperfiltration at the remaining glomerulus. So when this occurs, first they will activate the RAS system, renal angiotensin allotroph system. I believe everyone know what is this. I will not further explain about it. So when the RAS system is activated, it will result in the hypertension and also some nephrotoxic inflammation and remodeling. And also other mechanism is when the other glomerulus is in a hyperfiltration state, it will increase the glomerular permeability and it end up increase the filtration of the proteins and macromolecules. So it end up also in the proteinuria and nephrotic inflammation of the or remodeling of the kidney. So all of these will result in the tubular interstitial fibrosis in a long term. And our kidney reduce its glomerular filtration rate, reduce urine output, and also it results in many of systemic complications that I will explain later. So next, just a quick recap. Why our kidney is so important? What is the functions? We can remember it by these acronyms. A wet bag. So A, acid-base balance. It maintain our acid-base balance. Second, W, water balance, maintain our water balance. E, electrolyte. And T, remove the toxin from our body. So B, bad. So B, control the blood pressure. E, making erythropoietin hormones to make our red blood cells in the bone marrow. And the last one is the vitamin D metabolism. So what happens when our kidney cannot do all of this? When there is when there is a lot of pathology inside it, such as hyperfiltration injury, proteinuria, hypertension, hypophosphatemia, and hyperlipidemia, it can cause a lot of complications next. So according to the Nelson 21st edition, this is just a quick recap also. The first one is hyperfiltration injury. Like in the diagram before, when there is a remaining nephron, when half of the remaining nephron trying to adapt the function of the kidney, it will change in the structural and functional, become hypertrophy, and increase the glomerular blood flow, and end up in they try to increase the glomerular filtration, and when this goes for a long term, it will damage the surviving glomeruli and end up in sclerosis the nephron. The second ones, when the proteinuria is a cause when proteinuria already manifests, the protein will have a direct toxic effect on the tubular cells of the nephron, and it will recruit more monocytes and macrophage. So when this happens, it will increase the inflammatory reactions inside of the nephron, and also will further damage the glomeruli and sclerosis it, and also fibrosis it. So the third pathogenesis is hypertension. When there is hypertension occur, the same mechanism when there is a hyperfiltration injury, and it will end up with the atrial nephrosclerosis also. When the blood vessels is become thick, I will not for the explain because it become too lengthy. So the next one is a hyperphosphatemia. Hyperphosphatemia when our kidney cannot excrete the excess phosphate in our body. So when there's too much phosphate in our blood, we lead to the calcium phosphate deposition in the renal interstitium and also blood vessels. We also will worsen the kidney condition. And the last one is the hyperlipidemia. Hyperlipidemia will affect the glomerular functions through the oxygen-mediated injury. Okay, next. So, according to the 31st edition, this is a summarized table of the pathophysiology of the chronic kidney disease. From this, you can see the results of the CKD is hyperkalemia, and the mechanism is like when there is a decrease in glomerular filtration rate, and our kidney cannot excrete the H+ more, and resulting in the metabolic acidosis. And then it can excrete the potassium, so excessive potassium, and we took excessive potassium intake, and all this will end up in the hyperkalemia. So there is a lot of the pathophysiology of chronic kidney disease. This is just a summarized table, so you can read on it later on. Next. Okay. Next. Okay. The symptoms of the chronic kidney disease, I will summarize in this picture. When first, in the early stage, like stage 1 and stage 2, patient will come with with no symptoms. And when the process become worsen, they can have a feature of volume overload such as ascites, edema, and heart failure symptoms. Second, polyuria or oliguria. So it's an inability to concentrate the urine, so become they will become very dilute. And the next one, electrolyte imbalance, so they have hyperkalemia and hypernatremia. And next one is the azotemia. So azotemia, when our body cannot excrete the excess urine. So when the excess urea. So when the urea is built up in the blood, resulting in lethargy symptoms, anorexia, nausea, vomiting, and also it can alter our mental status. And the next one is metabolic acidosis, anemia, hypertension, renal also dystrophy, and also short stature. All of this is a complication of the chronic kidney disease. I will explain it during the managing part. Next, so this also summarize clinical features of the chronic kidney disease. As you can see from the appearance, usually patient looks paler due to the anemia, hypertension, shortness of breath. And also if from the kidney points, when you do the imaging, sometimes they can give a clues such as bilaterally small kidney, with thin cortical, like in a glomerulonephritis disease, or maybe unilateral small kidney, according to the etiologies of the chronic kidney disease. And the second next symptoms could be itchy and cramps due to build up of the urea in the blood, and it's most common occur in the advanced stage of the chronic kidney disease. Next one is cognitive changes, also maybe gastrointestinal symptoms, change in the urine output, hematuria, proteinuria, and also peripheral edema. So all of the clinical features, it depends on the etiology of the chronic kidney disease and also the severity. Next. So usually investigation that we order in patient who has chronic kidney disease is first is full blood count. So full blood count, the normal result that we could usually patient will have is normochromic, normocytic anemia. And second one, we order for renal profile. So in the renal profile, we have high reading of urea and creatinine, also high reading in potassium, and maybe result in hypernatremia or hyponatremia. So we should also serum electrolyte, and there is increase of phosphate, but loss in calcium, hypocalcemia and hypophosphatemia. Next, we will take a liver function test. So in patients who have chronic kidney disease, they will have a hypoalbuminemia. We check also for the lipid profile, where there is a hyperlipidemia, increasing cholesterol, and also triglyceride. We check also serum uric acid, usually resulting in high in the blood. The next one is urinalysis. So urinalysis, we want to look for the we look for evidence of hematuria, proteinuria, and next one, we calculate the GFR, and from the GFR, we will stage the chronic kidney disease, and we also took protein to creatinine ratio. Usually is more than 30 milligram protein per creatinine. And the imaging that we can order is a kidney ultrasound to look for the morphology of the kidney, maybe small atrophic kidney or normal. And the last one, maybe renal biopsy, and the result maybe show excessive renal interstitial fibrosis or tubular atrophy. So all of this investigation also depends on the etiology of the chronic kidney disease. Okay, what is the principles of management in the chronic kidney disease? So we aim to replace or we aim to We aim to replace the absent or diminish the renal functions by treat the underlying disease. And when we treat the underlying disease, we want to slow the progression of the renal dysfunction in hope to reserve the residual renal function. And the next one, we want to prevent the complication of this KD, but when the complication occur, we will try to manage it. And the last one, and the last management is for the alternative treatment as a preparation for the kidney failure. So children with chronic kidney disease, they should be treated at a pediatric center where is capable of having multidisciplinary services, including medical, nursing, social service, nutritional, and also psychological support. Yes. So the first principle is to treat the underlying disease and mostly due to the acquired or anatomical problems. So if it's due to the ulcerative neuropathy, we further with the surgical management. If it's due to the nephrotic syndrome, we treat the disease with giving steroid and follow the guideline of the management of the nephrotic syndrome. If it's due to the congenital or genetic, usually it's incurable, so we can only control and slow the progression of the disease. Next, the second principle of the management. So how to slow or prevent the progression of the kidney disease? First, by optimal control of hypertension. So in the Nelson, it said that we need to maintain the blood pressure at lower than the 75th percentile and perhaps even lower. Usually they give a SEI inhibitors or angiotensin 2 receptor, ARB. And this is the most antihypertensive drug of choice in the hypertensive children with proteinuria renal disease. Now, later on, I will further discuss about it. The second one is maintain the serum phosphorus at the normal range. So they suggest that we should maintain it less than 55 milligram to minimize the renal calcium phosphorus deposition. The next one, from the treatment of infectious complications and dehydrations. So this one can minimize the additional loss of our renal parenchyma and correct the anemia, control the dyslipidemia, and avoid NSAIDs or other potential nephrotoxic medications. And the last one, to practice healthy lifestyles, avoid smoking, prevent obesity, dietary restrictions, and also stay hydrated. Okay. Next. So when there is already the complications of this KD occur, such as sodium retention and volume overload, hyperkalemia, metabolic acidosis, hyperphosphatemia, hypocalcemia, and anemia, we will manage the complications according to it. Next. So the first one. So for the sodium and water. So children with the chronic kidney disease, mostly they maintain a normal and water balance. But infants and children whose KD is a consequence of the renal dysplasia. Usually, there may be a presence of polyuria with significant urinary sodium or free water losses. So in this kind of patient, they may benefit from high volume, low caloric density feedings, which is a diet that tends to provide less fats and more water and fiber. So this is good for children with renal dysplasia, and additionally, we give a sodium supplementation. But for children with CKD with a presentation of high blood pressure and symptoms of edema or heart failure, in this kind of patient, we manage it by with restriction of the sodium diet, and also we give the diuretic therapy. And we must remember that fluid restrictions is rarely necessary in the children with chronic kidney disease until they have development of the end-stage renal disease, and when they requires the initiation of the dialysis. So that's for the management of the sodium and water. For the hyperkalemia, we restrict the dietary potassium, and we can administer the oral alkalizing agent and or with thiazolate. Okay, next. So second complication is metabolic acidosis. So metabolic acidosis develops almost in all children with the CKD because there is a decrease of the acid secretion by the failing kidney. So usually it causes due to the decrease of amniocentesis, impact the bicarbonate absorptions, and decrease the acid secretion. So we treat it by giving the Bicitra 1 milli equivalent sodium citrate per ml or sodium bicarbonate tablets, 650 milligram, to use to maintain the serum bicarbonate level more than 22 milli equivalents per liter. Next, for the nutrition, nutrition management by the dietitian experience is a must in all the pediatric renal patients according to the NKF KDOQI guideline. So it must consult based on the individualized assessment based on their age, physical activity, their BMI, and their response in rate of weight gain or loss. So patients actually they need to receive 100% of the estimated energy requirement according to this criteria: age, physical activity, BMI. So also based on the guidelines, when the oral supplemental nutrition with increased calories or food volume is still insufficient, the tube feeding should be considered. And dietary phosphorus, potassium, and sodium should be restricted accordingly. Also, calories should be balanced between carbohydrate, unsaturated fats, and protein. So I didn't put it here. According to the guideline, protein intake recommendation is between 100 until 140%, according to the per dietary reference intake in children with stage CKD3. If the stage of the CKD is 4 and 5, it must take 100 on until 120%. And in children with stage 5 or need dialysis, only 100%. Okay, next. So for the anemia, we manage usually anemia in patients with CKD is primarily results in the inadequate erythropoietin production. So when it cannot produce erythropoietin hormone, it will affect the production of red blood cells, resulting in the anemia. And usually, anemia is a symptom where it manifests in the patients with the stage 3 or 4 CKD. Stage 1 and stage 2, they rarely have an anemia. And maybe other contributory factors such as iron, folate, or fetal deficiency, and decrease in erythroid survival could be the possible causes. So how we treat it? First, we give the recombinant human erythropoietin therapy. As research shows that the recombinant human erythropoietin therapy has decreased the need for transfusion in patients with CKD. So this erythropoietin is usually initiated when the patient's hemoglobin is lower than 10 gram per deciliter at a dose of 50 until 150 milligram per kilogram per dose. We give it subcutaneously 1 to 3 times weekly. And we adjust the dose to maintain the hemoglobin concentration between 11 and 12 gram deciliter. So all patients that receive the recombinant human erythropoietin therapy, we must provide them with either oral or intravenous iron supplementation. So patients who appear to be resistant to this treatment, we should be evaluated for the iron deficiency, acute blood loss, chronic infection or inflammatory state, vitamin B12 or folate deficiency, we can give another alternative option, which is darbepoetin alpha, or the brand name is RNS. Next. So for the hypertension, okay, the hypertension in children, they should follow a salt restricted diet, which is less than 2 grams per day. Okay, first, the thiazide diuretics is the thiazide diuretics such as hydrochlorothiazide. We give it twice a day with 2 milligram per kilo per day. So we give 1 milligram for morning and 1 milligram at the evening. This one is the initial hypertension antihypertensive agent for children who have mild renal dysfunction, which is stage 1 until 3 chronic kidney disease. But when in the patients that we estimate the GFR is falls below this range, usually in the stage 4 and 5, we give loop diuretic furosemide because thiazide are not effective anymore. So furosemide we give 1 to 2 milligram per kilo per 24 hours. We can give it twice daily or thrice daily. So SAI or ARB, such as enalapril, SAI, and also losartan. This is a drug of choice of antihypertensive medication in children who have proteinuric renal disease because of their potential ability to decrease the proteinuria and slow the progression to the ESRD. So we need to take the extreme care when using all of these agents, especially in the children with the advanced CKD. So they need to always monitor the renal function and also the electrolyte imbalance. So calcium channel blockers such as amlodipine or beta blocker propranolol and centrally acting agents such as chlorothiazide. So all of these may be useful as an adjunctive agents in children with CKD who blood pressure cannot be controlled using the above treatment. Salt restricted diets or diuretics such as loop diuretic and also thiazide. So we can go to the another line of management. Next, for the complication of the growth, so short stature is a significant long-term sequel of childhood CKD. So apparently, children with CKD, they have apparent growth hormone resistant state with elevated growth hormone levels. But they have decreased in their insulin-like factor 1 levels. So all of these in a long terms, patient who remains less than 2 standard deviation for height, despite they took the optimal medication support, they took adequate calorie intake, effective treatment of the renal osteodystrophy, or correct the anemia and the metabolic acidosis, they might benefit from treatment with pharmacological doses of recombinant human growth hormone. So we give it in 0.05 milligram per kilo per day subcutaneously. So so we adjust this treatment with the periodic adjustment according to the achieving of the goal of the normal height of for the patient's age. So we continue the treatment of the recombinant human growth hormone until patient reach the 50 percentile for the mid-parental height, or when they achieve their final adult height, or they undergo the kidney transplantations. So long term of the recombinant human growth hormone treatment significantly improve the final adult height, and they can induce the persistent catch-up growth. So some patients may achieve a normal adult height. Next. So renal osteodystrophy. So this is another complication of the chronic kidney disease in children. So it's a spectrum of the bone disorders, and the term renal osteodystrophy is used to indicate multiple skeletal disorder due to the renal disease. So the most common condition seen is a high turnover bone disease that caused by the secondary hyperparathyroidism. So the skeletal pathology finding in these conditions is osteitis fibrosa cystica. And next. So the clinical manifestation of the renal osteodystrophy, patient may have muscle weakness, bone pain, and fracture, even with a minor trauma. In the growing children, they can have a varus or valgus deformities of the long bones, and slip capitofemoral epiphysis also may be seen. And when they do the imaging, the results show the subperosseous resorption of the bone with widening of the metaphysis, as you can see at the image at the right side. Okay, I'm sorry, back to the slide before. So what is the pathophysiology of the renal osteodystrophy that can result in the particular clinical manifestation? So actually it's a complex it's a complex disease where in the early course of the CKD, as you can see from this picture, okay, when there is a decrease in the glomerular filtration rate, approximately half of the function of the nephron cannot function well. So when there's a decrease in the GFR, that leads to a decline in the renal 1-alpha hydroxylase activity. So when this 1-alpha hydroxylase activity is reduced, it cannot converse the 25. It cannot produce activated vitamin D, which is 1,25-dihydroxycholecalciferol. So when this activated vitamin D cannot be produced, it results in the deficiency in the activated vitamin D, result in decrease the intestinal calcium absorptions, and resulting in the hypocalcemia. So this hypocalcemia will send the signal into the parathyroid gland activity to increase its activity by increase the PTH parathyroid hormone secretions. So the PTH attempts to correct the hypocalcemia by increasing the bone resorption. So furthermore, it resulting in the osteolysis. So it tends to correct the hypocalcemia in the blood, but we end up with the secondary hyperparathyroidism. So later, in the course of the CKD, when the GFR is declines to the 20 or 25% of its function, the compensatory mechanisms that they try to operate cannot more longer continue. So this resulted in the hyperphosphatemia, which further promotes the hypercalcemia and further increase the PTH secretion. So all of these will lead to the secondary hyperparathyroidism, where they call it as a trade-off hypothesis. When you want to try to achieve one thing, but at the end you end up with the unbenefit one, which is hyperparathyroidism. Next. So in the renal osteodystrophy patient, the goal treatments are to prevent the bone deformity and normalize the growth velocity using the pharmacologic and also dietary interventions. So when you took the investigation, it will show the decrease in serum calcium, increase in phosphorus level, and also increase in ALP reading. So the treatment is we target the phosphorus level for children between 1 to 12 years of age is 4 to 6 milligram per deciliter. And children and adolescents should follow a low phosphoric diet. And infant with this kind of condition, we must provide them with a low phosphorus formula such as Similac 60/40. So because it is impossible to fully restrict phosphorus intake, especially in children. So phosphate binders are used to enhance the GI phosphate excretion. And also vitamin D therapy is indicated in patients who their active vitamin D levels below the established goal range for the child. And patients with low or activated vitamin D, we will treat them with giving 0.01 until 0.05 micromilligram of calcitriol. Okay. Next. So the 4 principles of the in managing of the chronic kidney disease is the preparation for the kidney failure. So this is represent the stage of the hemostasis, and the survivors can no longer be sustained by the native kidney function. And we will further up to the renal replacement therapy, either by hemodialysis or peritoneal dialysis. And the last result is the renal transplant patients when there is an available donor, and which is the best option. Next. Before we go to the prognosis, I just want to add another management that we can add in the chronic kidney disease patient is immunization. So we need to continue all the standard immunization according to the schedule for the healthy children. Exception, we need to withhold the live virus vaccine from children with CKD due to the glomerulonephritis or during the treatment with immunosuppressive medication. And it's also recommended to patients who have CKD to receive a yearly influenza vaccine. And because many drugs are excreted by the kidneys, so we need to adjust the dose in patients with the CKD so that we can maximize their effectiveness, and also we can minimize the risk of the toxicity. So ideal strategy is we lengthen the interval between the dose, or we decrease the absolute dose, or both. Either lengthen the interval of dose or decrease the dose. So prognosis. Okay, pediatric CKD prevalence is approximately 18 per 1 million in children. So the prognosis for the infant, child and adolescent has improved dramatically actually since the 1970s due to the aggressive nutrition support, given the recombinant erythropoietin, recombinant growth hormone, dialysis techniques, and kidney transplantations. So usually in children with mild CKD, stage 1 and 2, they may do well, but need to be monitored for the progress of the loss of the kidney function. But with children with stage 3 and 4, they have a high likelihood to progress to the ESRD. And the children with renal transplant generally do well, but they have to take immunosuppressive medication such as prednisolone, traconimus, and azathioprine. And it holds many side effects. And the children on the maintenance of dialysis, they have the highest morbidity and mortality rate, especially with the longer time spent on the dialysis. And at the end, the primary goal is to receive the kidney transplant because it's the best option. Okay, next. So this is the list of the reference that I use from the NASA and also guideline updated on
Okay, yeah. So
that's all from
finish. They're very details, and looks like hearing from nephro consultant. So very details, so you look the difference between acute and chronic tadi. Tadi the message, if acute usually it is reversible, yeah. So that's why, and it is emergency. So that's why the approach to to manage the acute kidney injury itu ya, you do it very quick, very responsive to the problem. So we might hope that the condition is reversible and then a patient can back to normal. But different situation if we have patient with chronic kidney disease, it is already known problems kan. We know that the prognosis usually poor, especially kalau udah end stage kan. And then the disease will progress to end stage tadi kan, from the stage 1 until end stage. So what we do is not to do very quick or rapid response management. It is we need to well plan the management because it will be very long term management. Yeah? Not only months, maybe years. Yeah, to how to manage only one patient with chronic kidney disease. We need to monitor the GFR every 3 months, for example. Itu pun kalau yang good situation. Kalau very poor, maybe monthly, maybe gonna admit the patient and close monitor in the wards. So depend ya. So need well plan ya, di different situation. Kalau acute tadi kan emergency, we need to quick respond. Kalau yang chronic nih, we need to well plan the critical situation ya, because not really an emergency ya. Kalau emergency usually critical situation, but not all critical situation are emergency. Macam ni kan chronic kidney disease is critical situation tapi not emergency. We need to plan it very well, multidisciplinary approach. We need to we need to handle so many problems kan, from medications, diet, complication, and so on and forth. So that's why kan different situation kan. Kalau acute emergency itu everybody must know, must be able to treat. Ya. Kalau chronic nih kan, so need the one who can focus only to treat the patient. Kan. Even me as general pediatrician pun, it will be very difficult to manage even only one patient with chronic kidney disease. This need consultant, yeah, the one who know very deep on the situation and then can handle the many problems too. Kalau saya ada patient CKD, I just refer to nephrologist yang senang, because nephrologist dia akan very fokus kan, have very deep knowledge and skill to handle to manage the patient. So macam tadi Aisyah present tu very deep kan, so need to know very details in so many situation or problems. So I think this the take home message from this two. So kalau you nak able to handle CKD ya kena jadi nephrologist dulu, kena you cannot handle it by yourself. Apalagi kalau nak fikir hal lain, ada patient CKD dengan patient dengue, baik saya handle patient dengue, patient CKD susah nak manage ya. Alright, maybe any questions?
Doctor, for the patient CKD with hypertension, is
Yes.
there the target BP control untuk dia? Macam below berapa percentile?
Siapa? Aisyah? Jawab dulu. Control punya question.
Yes.
Target
Well,
BP control. Yes.
Ada je.
Just now you
Ada.
mentioned 75th
75th percentile.
Ada. Tadi detail kan one by one. Kalau bukan konsultan tak hafal. Kalau konsultan dah terbiasa kan, betul self ya. Can easily answer kan. Kalau macam kita kan, kita kena review again di di slides, di references. Kita tengok. That's very detailed protocol. So should be less than 75th percentile. So your common patient with edema, we give diuretic first. But usually, if no more edema, we give nifedipine. Sometimes we can combine juga. And then next is beta blocker usually to be given. to give ACE inhibitor, captopril, we need to make sure there is no renal artery stenosis. Okay. Need to do Doppler ultrasound. Okay, Badrul, clear?
Yes.
It's okay lah kalau you have CKD itu bukan you yourself yang kena manage all. Just usually consultant who give nephrologist who give plan management, we just continue lah, just follow the instruction je. Oh begini ni as long as PP lah tak sampai settle should be okay. Kalau BP still high, ya kau kena add on lagi antihypertensive agent. Yes?
Doktor, kiranya macam in children with hypertension, so kalau kan usually kalau macam adult kita kalau nak bagi ACE atau ARB, we just give a trial first and then kita monitor dia punya serum creatinine. Kalau rise more than 30% tu baru kita macam screen for renal artery stenosis. So kalau macam children, kita kena buat ultrasound dulu baru boleh bagi ke ataupun start with trial first?
This one preference from nephrologist lah, because we have so many options of antihypertensive agent. Yeah, it is safer if we do ultrasound first before start ACE inhibitor. But let's say if the situation is different, yeah, if in emergency, kalau macam AKI tadi, acute kidney injury, we need to handle the situation in responsive manner kan. So kalau memang if it is necessary, we can give captopril even though before ultrasound. But this chronic kidney disease, it is again it is a long-term chronic situation that we should anticipate kan. So better we do ultrasound dulu lah before make sure tak ada renal artery stenosis, because if renal artery stenosis it will be worsened kan with ACE inhibitor. So before we have ultrasound, we give other antihypertensive agent dulu. So usually a diuretic lah, the one who is the first choice, because patient usually with edema, diuretic, and then give nifedipine, CCB, and then beta blocker. So that's why. Unless if we don't have so many options, we have a few options, and then we can anticipate. We not necessarily the patient will have yesterday normal, now hypertension. Chronic kidney disease is chronic situation again. We will know the BP itu dah lama dah hypertension. So we treat itu accordingly lah, step by step, and then we have time lah. Different kalau with acute tadi emergency situation, we don't have time. Time is we need time dependent. We need to very responsive. Kalau chronic ni we have time. We still have time to do ultrasound. Even 2 to 3 weeks later pun it's okay. Now we can manage with other antihypertensive agents. But again, it's this very specific subspecialty punya approach, consultant punya level. Usually final decision ya based on the consultant lah. Kalau consultant nak bagi dulu, okay, dia follow je. No need to overburden yourself lah. Kalau in your level, but more kalau nanti jadi hostman KMO, no need to overburden your level of capacity itu nanti how to recognize the situation, diagnose, and then report lah. Oh, patient hypertension, doktor nak bagi apa? Ditanya lah. So the specialist consultant will decide. Okay. Alright. Okay, yeah. So any more question maybe tadi? So we go to the last topic, last but not least. yang tadi dah more than 30 minutes lah. Very details. Saya pun tak boleh accept semua lah. Banyak yang tak saya pun miss and then not understand actually. Right. And this one should be simple ya, Enuresis ni. This because common clinical complaint usually patient complain with Enuresis ni simple situation je. Yang ni ringan-ringan je yang ni. Okay, Amirul, present.
Okay, hello guys. Assalamualaikum. My name is the great Muhammad Abdul Arif Mausi. So with me, we're gonna have a little bit more fun talking about Enuresis. So I think this is the first ever seminar that you have. Most of you have since you were born. So let's talk about that. Next. This is the outline. Okay, next. Let's first talk regarding the important part, which is the definition. So, National Essential, they state that enuresis is urinary incontinence in child who is adequately mature to have achieved continence. And in up-to-date, define enuresis as it refers to discrete episode of urinary incontinence during sleep in children for at least 5 years of age. And from KKM website, Kementerian Kesihatan Malaysia website, enuresis is the medical term for bedwetting. It is where a child involuntarily pass urine during sleep. So in easy words, we can say that enuresis is urinary incontinence in a matured child that we expect to not have urinary incontinence. So let's talk more about that. Next. This is the diagnostic criteria from DSM-5, where they define the enuresis as following the diagnostic criteria, a few diagnostic criteria. First is repeated voiding of urine into the bed or clothes, whether involuntarily or intentionally. And next is this behavior is clinically significant by frequency at least twice a week or at least 3 consecutive months, for at least 3 consecutive months. And the chronological age is at least 5 years old. And this behavior is not attributable to the physiological effect of substance or other medical condition. And in DSM-5 also, they need us to specify whether the enuresis is nocturnal only, where the enuresis happen during nighttime sleep, or diurnal only, where the enuresis happen during waking hours. And also there can be also combination of these two subtypes. Next. So to make it easier for us to remember, enuresis happen in a child at least 5 years old and above, at least twice a week in 3 consecutive months. So that's about definition. So I hope you guys remember regarding the definition of enuresis. So next. Okay, next we will talk about the classification. So classification of enuresis, I think personally is very important, because this is important for communication between the medical officer or medical attendant lah. And also you can estimate as well regarding the underlying causes based on this classification. So the classification can be monosymptomatic and also non-monosymptomatic. And for monosymptomatic, can be subdivided into primary and also secondary enuresis. Next, let's talk about that. So next, for monosymptomatic, as you can see from the name, monosymptomatic gives us the clue regarding what is going on. So monosymptomatic means that enuresis in the child. So enuresis is the only symptom without any other lower urinary tract symptom, and without also history of bladder dysfunction. On the other hand, for non-monosymptomatic enuresis is not the only symptom, but we also have other lower urinary tract symptoms, and also history of bladder dysfunction, and also bowel dysfunction. And the incident is more common with the monosymptomatic enuresis. So next. for monosymptomatic enuresis, I said before that it can be subdivided into primary and secondary. For primary enuresis is for children who have never achieved a satisfactory period of nighttime dryness. On the other hand, for secondary enuresis, children who develop enuresis after a dry period of at least 6 months. So in easy words is that primary enuresis, the children never had dry period. On the other hand, for secondary enuresis, the children had dry period and then developed enuresis. So you need to remember this classification. Okay, for monosymptomatic, like I said before, only enuresis symptom. For non-monosymptomatic enuresis, there are also enuresis plus other lower urinary tract symptom and primary and secondary enuresis. So that's about classification. Next. Next. So now, briefly, we just talk about the epidemiology of the distribution of this problem in the population, where, as you can see from the pie chart, of the children with enuresis, 20% wet during the day only, and 70% wet during the day and at night, and 61% wet at night only. So the most common incident is nocturnal enuresis, and also the prevalence varies according to age. So what I can conclude is that as the years go by, as the age increase, the incident of course will decrease, right? So not much to talk about the epidemiology. Next. Okay, for the causes of enuresis, there is actually long list of causes that lead to or urinary incontinence. In Medscape, they divide into causes primary enuresis and also secondary enuresis. And some of these disease, they can cause both primary or secondary enuresis. As you can read, the cause can be idiopathic disorder of sleep arousal, nocturnal polyuria, and cystitis, constipation, neurogenic bladder. There's a long list. So if you want to know details regarding on how these disease lead to enuresis, you can read by yourself. So next. So now the core of my presentation, where we will talk about the clinical approach. You can imagine, for example, a 6-year-old come with the chief complaint of bedwetting, and this condition was making the mother worry. You can imagine that situation, and then how will you manage that problem? How will you approach this kind of patient? Before we talk about, usually the approach, of course, history taking, physical examination, investigation, and then we manage. So before we talk about that, you need to know that this enuresis actually have a significant psychological effect on a child, because you can imagine yourself bedwetting. So there, of course, psychological effect. For example, the child may loss of self-esteem, they feel shame, and also they can have anxiety and also depression due to the condition. And they may get psychological punishment like verbal punishment from the family member or friends. This may affect the school performance of the child. That's why the enuresis is not the problem that we can take lightly. So we need to manage properly. So right, next, how we want to approach the patient that come with bedwetting. First, for history taking, you need to ask first what type of nocturnal enuresis. Like I said previously, whether we want to know it is primary or secondary. So you ask the history of whether the child has consistently dry at night or not. So if the child have the dry period, so this is if the child never have dry period, never have dry period, this is suggestive of primary nocturnal enuresis. On the other hand, if they did have a dry period and then they develop enuresis, that's secondary nocturnal enuresis. Next. So the other important thing that we need to ask is regarding the family history, where we ask whether the parent have childhood enuresis or not, because the enuresis is usually transmitted in an autosomal dominant fashion, and this make, if the parent have the childhood enuresis, the child will have higher risk to get child enuresis. And for this, if the patient did have enuresis, childhood enuresis, you need to ask at what age of resolution in the parents, because this can guide expectation for resolution in the child. So that's about family history. Next. In history as well, it is important for us to ask, to look for the possible cause that lead to enuresis in the child. For example, you need to ask whether the urinary incontinence happen at night only or day and night. For example, if the child has history of urine control problem during the day, including daytime incontinence, significant urgency and frequency, this may suggest that the patient have UTI or overactive bladder or ectopic ureter. Next. Next, constipation. Constipation also important for us to look for in patient because the constipation can be either the cause or can be the aggravating factor that for enuresis that happen due to other factor. The proposed mechanism on how constipation lead to enuresis is that one of the proposed mechanism is the impacted stool inside the sigmoid colon will restrict the capacity of the bladder that lead to the enuresis. So you ask regarding how often does a child have bowel movement, are the bowel movement associated with pain or bleeding, does the child have to large enough caliber to clog the toilet, and also does the child have unintentional fecal voiding. For unintentional fecal voiding or fecal incontinence, it is encompasses. There is we need to ask about this as well because there is studies state that there are significant relationship between encopresis and also enuresis. So next. Next is we need to ask regarding OSA as well, obstructive sleep apnea. At first I read about this. It states that OSA is important cause that lead to enuresis as well. But initially, I think why does these two not really related system can cause enuresis, right? So the proposed mechanism is that OSA can lead to reduction of production nocturnal antidiuretic hormone or nocturnal ADH, and also lead to increase in ANP, atrial natriuretic peptide. This will lead to increased production of urine that will lead to nocturnal polyuria. So we asked regarding the symptom of OSA, whether the child have snoring, gasping for air, mouth breathing, cyanosis, daytime somnolence, irritability, and other symptoms related to the OSA. So next. Next is we look for functional bladder disorder. This is common among girls in the preschool or elementary school, where the presenting complaint usually urinary frequency, urgency, squatting behavior, daytime waiting, and also enuresis. So you can ask whether the child have to run to the bathroom or ask whether the child hold urine until the last minute. Does the child ever wet more than once a night? So next. Other thing that you can ask for functional bladder disorder is that the frequency of voiding, how many times does the child void in a day. For example, if the child void more than 7 times a day, which is quite a lot for a normal person, so they may suggest for functional bladder disorder. Next. Next thing in history taking, we need to look for nocturnal polyuria, where nocturnal polyuria is urine production greater than 130% of the child expected bladder capacity. So that is calculation for expected bladder capacity. And also we need to differentiate between the nocturnal polyuria and also functional bladder disorder, where you can ask regarding how many nights a week does your child wet the bed. If 1 or 2 nights the child wet the bed, it's suggestive of nocturnal polyuria. If most of the night the child wet the bed, it is a functional bladder disorder. Next. And also we can differentiate between functional bladder disorder and also nocturnal polyuria by asking the volume of the urine after when they bed wet. If the urine is large volume, it is suggestive of nocturnal polyuria, and if small volume, functional bladder disorder. So next. Just now we asked regarding the symptom or history that we look for the causes that lead to enuresis. So we also need to ask regarding the parent whether they have tried any treatment or not, and if they did try for treatment by their own initiative. Be alert for response suggesting that the child has been punished or shamed due to the failure of treatment. And also we need to look for psychological stressor like burst of new setting, death of relative, trouble in school, abuse, and also divorce, because psychological stressors also can be the etiology for enuresis. Next. Lastly, in the history taking, we need to ask regarding the interest and motivation of the child, because this is important for the future management, where you ask the child whether he or she is bothered by the problem or not, because one of the treatment is behavioral modification, so it is unlikely to be successful if the child is not interested to participate in the treatment. Okay, next. So just now we talked about the history, we got a general idea what's going on to the child. So now we want to do physical examination. The PE for enuresis is not only genital examination, but we need to do complete physical examination for head to toe. We look for the clinical sign that may suggest the causes that may cause or may lead to enuresis. For example, large tonsil may suggest of OSA, abdominal mass, may suggest of constipation or encopresis. Large kidney, large bladder may suggest of hydronephrosis or nephrotic bladder. Next. We also need to identify the anus or vaginal opening and also urethral opening. If the vagina or urethral opening is not seen, it may suggest labial adhesion. And labial adhesion is one of the common cause of recurrent UTI in a female child. And also we look for skin changes from the chronic wetness or irritation in ectopic ureter. Ectopic ureter is the ureter insertion is not at the lateral bladder tricon. It's at the other place. Next. Sometimes the child underwear also can give us clue regarding what's going on. For example, you check the underwear of the child to assess for wetness. If the wetness is continuous, it may suggest of ectopic ureter, and also if there is two streaking, it may suggest for encopresis. You need to inspect as well to around the anus and also perianal and or fissures to suggest of encopresis. So other investigation that is critical also is the look for sacral dimple, tuft of hair over the midline, abdominal or asymmetric gluteal cleft, because these we suggest any position at the third cord, like the third cord lipoma, persistent dural sinus. So that's about physical examination. So just now we talk about history, physical examination. So we might get the idea regarding what caused the enuresis, and we might exclude all the possible diagnosis that may cause the enuresis. So now we want to do investigation. For investigation, enuresis is the investigation that we need to done to every single enuresis case. So next. For urinalysis, we look for clue that show for underlying problem like urinary tract infection, diabetes mellitus, or diabetes insipidus. Once or for other investigation usually are not required unless there is clinical indication that make us need to do other investigation. So next. This is other investigation that can be done. For example, urine culture. If the white blood cell on urinalysis is positive, and ultrasound can be done, ultrasound of urinary tract can be done to look for hydronephrosis and other abnormalities. And voiding cystourethry if we suspect any underlying anatomical abnormalities. MRI spine is during the examination that we've done, there are abnormalities, and do MRI spine. So that's about investigation. The most important thing that you need to remember is that for investigation is urinalysis is the most important and need to be done in every case of enuresis. So next. Now for principle of management, if patient comes with enuresis, how you want to manage this kind of patient. So for the goals, you can read by yourself. Mainly, we want to reduce the number of wet nights, and we for referral, we refer if there are clinical or radiographic findings suggestive of renal or urologic abnormality of the overactivity. So next. for definitive treatment. Definitive treatment, this is like an overview regarding definitive treatment. The thing that we need to know is that primary monosymptomatic nocturnal enuresis has high rate of spontaneous dissolution. So usually we do not need to take any medical intervention. But if we did need medical intervention, you can see we can educate and reassure the parent that given the high rate of spontaneous dissolution, we can also do motivational therapy, which is the behavioral modification, and enuresis alarm, which is the most effective long therapy, and desmopressin, which is the drug. This is effective in the short-term therapy. And also for secondary nocturnal enuresis, we need to take the underlying cause. Actually, not only secondary, if primary nocturnal enuresis, if there is underlying cause, we need to treat the underlying cause. So let's talk a bit about the treatment next. First is behavioral modification, which is the most important treatment in enuresis, where we need to educate the parents to reward for dry nights, reward the child for dry nights, and positive reinforcement may enhance the treatment result, and punishment has no role to play in the behavioral modification. So next. In behavioral modification also, we need to educate the child to frequent voiding during the day and always before bed. And during the voiding, the child should relax and use optimal posture and take time to empty the bladder completely. And at school, we want to avoid the daytime enuresis. We ask the child to void regularly at least 2 or 3 times daily. And we also educate the child to drink liberal amounts during the day so that he drink for that day, so that at night there will less consumption of water. Next. That's about behavioral modification. So now regarding the alarm enuresis, this is also the first line therapy or treatment for enuresis and the best. Of all treatment of nocturnal enuresis, the alarm is one of the most effective and has the best long-term cure rate and also less recurrence rate. Next. Okay. Actually, for alarm enuresis, actually a device where there is a sensor and also alarm. So this sensor will be put in the diapers, and if the child, for example, wet at night, so the sensor will detect the first urine drops, and it will cause the alarm to make sound. So the parents should awaken the child when the alarm sounds, and the child should void in the bathroom, and then edge parents in changing their bedding before returning to bed. Next. So how long we want to treat the patient with alarm enuresis? We should try for at least 2 to 3 months. And when we want to stop the alarm enuresis is until at least 14 consecutive dry nights are achieved. If for example, if we stop and lapse occur, and then we can have a second trial of alarm therapy. That's about alarm therapy. Next. So surprisingly, there are also medication to treat enuresis. The first drug that we want to talk is the mechanism of action is it is a vasopressin analog that reduces the amount of urine produced at night. So the age of child that should be given is 6 years and older, and we give this drug at the bedtime. So we cannot give in the morning. So next. Next, it is important for us to consult the parent regarding the possible side effect or complication of desmopressin, where we ask parent to instruct the patient, to instruct the child to limit the fluid consumption starting 1 hour before the medication is given and until the child wakes the next morning. So after it need to be at least 8 hours of fluid restriction after the drug was consumed. So if the child did not obey, for example, they take fluid after consumption of desmopressin, there will be fluid retention, hyponatremia, and also it can lead to seizure or even death. So next. Other thing regarding desmoid pressing is that if the child have acute illness with weak or electrolyte imbalance, we need to hold the treatment first because like we discussed previously, the side effect. They have hyponatremia and all. Okay, next. Next drug of choice is anticholinergic, like oxybutinin, but this is not recommended as first-line treatment in any child with nocturnal enuresis, but it is recommended if the DAVT or desmopressine just now, or the alarm therapy has failed. So, and also this anticholinergic drug like oxybutinin also work well in the case of enuresis due to the small bladder capacity and also overactive bladder. Next. Next. So the last drug that I want to tell you is amipramine, where this is a tricyclic antidepressant, where the mechanism of action is to stimulate ADH secretion and relax the dextrose muscle. But it is rarely being used because of the relapse rate is high and it is not considered first-line agent because based on more on their risk than their benefit and also the side effect, prolonged QT interval and also significant risk of death with overdose. So next. So for 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 summary of the management, for all case of nocturnal enuresis, regardless of age, we need to, for general management is we limit the fluid before bed, void before bed, and also regular sleep and wake schedule. Because regular sleep and wake schedule, we can estimate when the child will sleep, so we can ask the child to be before they sleep. Next. If the child age 6 years and older, we need to start active treatment like the alarm enuresis and also desmopressine medication. I think that's all. Next. This is what we have discussed. This is my.
All right. So any question? This one enuresis is apa? Common complaint in clinic usually. Yeah, patient not come to the ward usually because it is only a problem with enuresis. Patients usually still have apa? Well, growth and development. Any question before I ask maybe? Tak ada? Saya tanya lah. Siapa? Amirul. Simple definition kenapa dia kena more than 5 years. Baru kita diagnose enuresis.
Because most of the time, after 5 years, the child should be dry.
Dry apa?
The child should be dry, can control their voice.
So you refer to developmental milestone ya. So it is normal ya kalau by 2 years tuh baru dry by day. And then kalau nak dry by night tuh actually the milestone is 5 years. Memang is normal kalau below 5 years masih night wet, bed wetting is okay. It's normal. But after 5 years developmentally the child the children should be able to control the bladder movement by night. Yeah. So itu ya simple because this physiological development the milestone. So kalau umur 3-4 tahun ya bedwetting ya don't be angry ya. So kalau yang jadi parents your kid bedwetting umur 4 tahun ya jangan marah. It's normal. Currently pun we easily get the diapers kan. Selalunya saya pun bagi pasangnya diapers selalu malam baru 4 tahun lebih usually 5 years off. How do we off ya sebelum off tengoklah kalau tiap malam dah dry every night dah tak kencing baru kita off. It is normal ya. By 5 years, physiologically, developmentally, should be able to control the bladder. Okay. So tadi yang I want to highlight, yang first tadi lah, the developmental milestone, and then the second thing is tadi the classification ya, don't get wrong ya. Tadi yang primary and secondary is unlike hypertension kan. Kalau hypertension yang secondary itu ada causes ya. Kalau yang this one primary and secondary is a matter of timing aja. Yang primary means never dry. Kalau yang secondary dia sudah ada period of dry more than 6 months, tapi tiba-tiba ada problem ya. So yang another classification tadi yang primary and secondary is monosymptomatic kan, tak ada other issue. Kalau yang non monosymptomatic usually with other issue, it is more have clear causes actually. Yang kalau yang non monosymptomatic with other problems, maybe ada organic neurogenic bladder ke, small bladder ke, ada VUR, ada hydronephrosis, ada any few renal problem, kidney problem, or urinary tract problem ya. Nah, itu usually secondary, non monosymptomatic ya, ada with other problems. Ya. Kalau yang only enuresis, yang monosymptomatic, usually problem pun maybe ada ya, tapi most likely kan only psychological, only a matter of training ya. So that's why another keyword, another clue is toilet training. So usually we toilet train the child even since 1 year old kan, supaya by 2 years dia boleh dry by day, and then another sampai 5 years boleh dry by night. And then toilet train itu both kan bladder and bowel ya. So macam tadi kan dia usually dia common enuresis with encopresis. Usually problem dia poor toilet training atau dia ada psychological problem ya, stress, takut kena marah apa-apa. Okay, and then itulah how to recognize the bukan etiology ya, the underlying causes ya, underlying situation. And then how to manage. Drug itu is last choices ya. Most of the time, because most common kan monosymptomatic, primary. Usually with proper toilet train we should be able to even prevent actually. Tak sampailah jadi, jangan sampai enuresis baru kita treat ya. Better prevent. How to prevent ya toilet training. Proper. So, kalau terjadi memang udah 5-6 tahun masih enuresis ya we do toilet training juga actually. How to train ya itu to control bladder bowel, time management, when to urinate. So actually before kayak alam pun we can do our parents lah usually. Dokter only give advice kan, parents should be able to do time management. So kena tengok timing dia buang air pukul berapa. Sebelum tidur buang air, nanti kalau biasa pukul 1 tengah malam bedwetting, pukul 12 bangunkan dulu untuk urination. Contoh. Kalau susah sangat memang pakai alam lah. Terus alam pun I don't even see once in yang sampai lah. Kalau in the picture banyak aja kan, in the reference banyak, tapi saya rasa tak pernah jumpa yang barang itu macam mana. Better time management, and then proper toilet training, and then psychological treatment tu dia also important ya, bukan reward and punishment tapi reward only ya. Kalau kita punish, ini jadi more problem because most likely causes usually kan the stress, shame, dia malu, takut ya. Kalau with punishment dia lagi susah untuk handle, untuk manage. Usually our psychological treatment is reward ya. Kalau dia dry kita bagi star sampai, atau boleh lah kalau nak bagi some few food ke apa-apa. So, kalau dia suka coklat bagi coklat kalau dry, atau bagi some reward lah, bagi some gift kalau dia successful. Dan setelah next baru kalau perlu ya pakai alam, which is actually very effective, tapi lah difficult to get I think in our setting in Malaysia or more in Kuantan. Lastly kalau unsuccessful baru obat lah, baru desmopressin or others. Okay, that's all I think. Any more questions?
Doctor, for
Yes.
example, a patient is actually having a developmental delay. So should we treat the incontinence as per 5 years old?
No lah, because the delay kan ya the patient has their own punya achievement kan. Kalau his developmental age only 2 years ya, we should expect dia cannot dry by night kan. So we cannot force open a dry by night even though 5 years old kalau dia developmental delay only able to do 2 years old punya ability-nya. So contoh ya usually kalau pasien-pasien CP ini kan ya, it's common dia akan still bedwetting ya just use the diapers lah sampai even sampai older age pun is common pasien CP itu dia still need diapers. What more kalau the CP is cerebellar CP kan di ataxic apa dia coordination function dia bladder control dia will not normal. Tapi kalau yang spastic CP yang only motoric problem tuh usually we can treat lah, we can do toilet training, can educate the patient. Tapi the problem with spastic CP itu sometimes kalau dia very severe, even they cannot talk kan, so tak boleh cakap kan, bila nak buang air tu susah kan, so jadi problem lagi. The parents cannot know when is the patient will urinate, so you kena pakai diapers. Kalau patient with delay we cannot force. We discuss yang normal patient yang developmentally should be normal. Ya. Kalau delay ya ikut their ability lah, ikut their achievement of milestone. Yang this one kan non monosymptomatic ya, usually ada not only the enuresis, dia ada developmental delay, ya unable to talk, unable to walk, so ya kita treat the patient accordingly je lah. Okay. Alright. Next, any more questions? Yeah, clear ya. So thank you all to attend this holiday punya session. Maulid Nabi kita belajar harap dapat pahala insyaallah. Daripada you cuti tidur. Pagi-pagi saya sengaja buat pagi awal supaya dapat pahala sikit. Alright. Okay ya, let's close with Taufiq Farhan subhanallah. Alright, thank you all.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you again, insyaAllah. Assalamualaikum.
Assalamualaikum.
Thank you, presenter.